are going to be having a presentation by Andrew Bright, who's one of the consultants at Gateshead Health and also at Newcastle Hospitals, and Lisa Langley, who's a sister at Gateshead, who also has a special interest in allergy. So I'll hand over to you, Andrew. Thank you.
Thanks very much, Louise, and thanks very much to the ODN and NECTAR for inviting to come and speak to you today about anaphylaxis as part of these really useful webinars. I'm just going to share my screen. And we're going to be talking to you for about an hour. To introduce myself, I'm Dr. Andrew Bright. I'm a general paediatric consultant at Queen Elizabeth Hospital in Gateshead. I also do some allergy work there. I'm also an honorary consultant in paediatric allergy at Great North Children's Hospital and also do various network roles. I'm accompanied today by Sister Lisa Langley, who's a nurse with a special interest in paediatric allergy, who also works at QE. I'll take you through a brief agenda of what we're going to be talking about today. So first of all, I'll give you a little background on the topic that we're talking about. I'll then be a bit more specific and talk to you about the problems with anaphylaxis in children and young people that I see as being the main issues. Then a little bit of an update on the recently revised RC UK guidance, which came out in the latter stages of 2021. I'm going to talk to you about my favourite subject, BeatAnaphylaxis, for a little bit and take you through what exactly the project involved and what we're doing. We're going to have a really focused practical session from Sister Langley about adrenaline auto-injectors, the different types and their administration. She's also going to take you through these kind of mythical things, the personalised allergy action plans, and I'll talk briefly about adrenaline auto-injector risk assessment of patients. Then we'll have a little kind of roundup and summary, and there'll be a time for questions and maybe a short discussion at the end. If you can save your questions for the end, that would be great, but if they're really important at any point, you can stop us and we'll do our best to answer. So I'll jump the gun there a little bit, but I guess sadly the important thing to say, although it's very rare, anaphylaxis can kill. And that's no better exemplified than this very sad story about a girl called Ellen Raffle. Now, she was a 16-year-old young person who had a background of well-controlled asthma. She had dreams of becoming a space scientist and she had a whole life ahead of her. Really nice family and story. Tragically, she passed away in 2019 following an anaphylactic reaction to a food that she had eaten, as the coroner put it at the inquest. Now, this girl had previous allergic reactions to nuts and she'd been to an allergy service in our region and had some allergy testing, and it turned out she was positive for nuts, fish and shellfish. Now, why is this important? Well, I guess really poignantly, she's from Blythe, so just down the road. You know, a member of our regional community, families that we may come in contact with knew her and she was part of their local community. So it had a really devastating impact. I guess on a more positive note, out of her very sad passing came lots of good. And the family have kind of campaigned and set up a charity called Ellen's Gift of Hope. So I always do a little promotion about this as I work with them quite a lot. So anaphylaxis, a little bit of revision. I know you all probably know the definition of anaphylaxis, but we'll run through it quickly. So it's a serious, potentially life-threatening, generalized systemic allergic reaction. And its progression's usually rapid in nature. So you're usually seeing onset within 30 minutes of exposure to an allergen. Now, why have I double-crossed out severe? That's because the definition's changed recently, or certainly in the last 5 years. We've moved away from saying that anaphylaxis is always severe, because that can be unhelpful when thinking about our schema of this condition and helping us with recognizing it. It's always serious, but indeed there are grades of anaphylaxis, and we can have mild anaphylaxis. And I think lots of us will have experience of hearing about a patient that's maybe had an allergic reaction that sounds quite serious, but they've gotten away perhaps with minimal treatment and never had to have adrenaline. But as we'll come on to see about the criteria for diagnosing anaphylaxis, it can always be serious, lead to death, and the very sad story we've just heard about. It involves sudden onset of potentially life-threatening airway and/or breathing and/or circulatory compromise. And it's really important that that can happen with or without skin changes. So I think lots of us have this mental image about anaphylaxis involving really impressive facial swelling, a nasty urticaria or hives-like rash, but that isn't always the case. And indeed, in the sad case of Ellen Raffel I've just talked about, she had fairly isolated wheeze without any mucosal changes, leading to her collapse. It usually happens or can happen after exposure to a known trigger or allergen, but not always. And that's the other thing that foxes lots of people in the case of idiopathic anaphylaxis when no trigger is identified. And those cases can be misdiagnosed and not treated with life-saving adrenaline. I like to put this little extract from something that Sister Langley will talk to you about later, but it's the BSACI Allergy Action Plan. And I put it up there because although we all know the definition above, and I think anyone can reel that off if they've come across it or studied, actually as healthcare professionals in particular, we're pretty bad at recognizing the subpoints below each of those headings. These are the subtle symptoms and signs of anaphylaxis. And actually, this is where we fall down on recognition of the condition. So the problem with anaphylaxis, well, aside from the things I've already mentioned, it's quite a low frequency event, which is great because it doesn't happen that often, thankfully. But that means that we don't get well practiced in how to recognize it and how to manage it. So actually, we find it difficult to consolidate any teaching or training we get about managing it or experiential learning we have. An example of how low frequency, well, we've done some data work in region. And when we look back at the inaugural anaphylaxis paediatric audit in 2019, we see there's just 75 cases across all of the Northeast. That's 7 NHS trusts. And when we re-audited that, I'll come on to talk to you about the results of that bit of work in a little while. But when we re-audited it in 2021, we found that we just had something like 80, low 80s in case number, and that was across 8 trusts, including North Cumbria. That said, it's estimated that 1 in 300 of us will experience anaphylaxis at some point in our lives, and that the incidence of this might be increasing, as certainly the incidence of allergy in childhood is. Our foot recognition may be poor, but we know that it is poor. I've got quite a lot of data, certainly regionally, to back that up, that healthcare professionals are quite poor at recognising anaphylaxis promptly. And I, would reference our Northeast and North Cumbria Anaphylaxis Knowledge Survey, which we performed in 2020 and then repeated it again in 2022. Quite poignantly, there's a really heavy burden of specific discharge tasks or information management and education we need to give our children and young people who've suffered with anaphylaxis prior to discharge. And just to give you a flavour of that rather than go through every bit individually, this is the short list of things we've got to do every time we see a patient and they're admitted, and sometimes maybe not admitted, but we've risk assessed them as being at risk of anaphylaxis. So new guidance, let's talk to you about the Resus Council update. The old anaphylaxis guidance had been around for several years, and this is a really welcome addition, taking on board some new information and practice that we're all hopefully adopting. So what have they done? Well, lots of us remember the old algorithm. They've updated the color scheme. It looks beautiful. It's got a nice teal motif, but drilling a bit deeper, what's changed? Well, firstly, there's a real specific emphasis on positioning of patients depending on the type of compromise they have once anaphylaxis is recognized. Overall, we want to maintain the supine or semi-recumbent position, and we don't want to stand up patients if they collapse or if we think they're suffering with anaphylaxis. And those little stick figures, they actually mimic the same positioning advice we give our patients on our allergy action plans. There's also explicit instructions for early IM adrenaline above all other therapies, and very clear advice to repeat doses of IM adrenaline every 5 minutes if there's no improvement in the symptoms indicating anaphylaxis. Indeed, if you need to give a second dose of IM adrenaline on the other side or thigh, then we should consider also providing some fluid resuscitation support with a fluid bolus of usually crystalloid. Next, there's a new part of the algorithm, or a sub-algorithm, which we use in those cases where we've needed more than 2 doses of IM adrenaline, and that is progression to IV adrenaline infusion. And that's come out of data that's shown us that children or young people who need 2 doses of IM adrenaline, the vast majority will go on needing subsequent doses because they're in the certainly moderate to severe anaphylaxis range, and they're at great risk, and they often need an IV adrenaline infusion. There's also now, helpfully, a specific IM dose to give infants that are less than 6 months. So these might be the children that say are weaning early or have an immunization reaction, perhaps in a GP surgery. And that was always an age group where we were worried about overdosing them with adrenaline. But now we know that 100 micrograms to 150 micrograms, that's the junior adrenaline auto-injector dose, is safe to give in that age group under 6 months. Antihistamines are now third-line interventions and been completely taken out of the algorithm for immediate management. That said, non-sedating oral antihistamines do still have a place in the treatment of anaphylaxis. So things like cetirizine would be a really good option, but they should only be given post-stabilization once you've stabilized their anaphylaxis problem with adrenaline. And things like IV Piriton or chlorphenamine shouldn't really be used anymore, and certainly not IV or IM, because there's been an association, certainly the side effects of significant sedation, which can confuse your recognition of cardiovascular compromise, but also can exacerbate hypotension. Finally, corticosteroids, and quite controversially, things like IV, IM, hydrocortisone are no longer routinely recommended in emergency treatment of anaphylaxis. So I like to talk a bit more about that, because lots of people are initially certainly uncomfortable with that, because we've always used steroids. So why are we not using steroids anymore in the acute management of anaphylaxis? Well, there's no strong evidence that corticosteroids shorten symptoms, have an effect on acute anaphylaxis, or prevent the dreaded delayed or biphasic reactions, which are rare but can happen. In contrast to acute severe asthma, early steroid administration has actually been found to be associated with an increased risk of admission to intensive care units in children and young people. And that's after correcting case severities. There's some thoughts that that might be related to some unknown interaction with corticosteroid on the anaphylaxis cascade, but actually we think most likely that corticosteroids being part of that algorithm, it certainly historically has often delayed the use of second doses of adrenaline because people get tied up drawing up IV-IM medications and don't watch the clock for that 5-minute mark. Sometimes it even delays the initial dose of adrenaline, and certainly that's associated with poorer outcomes. That said, oral corticosteroids still have a role in the management of anaphylaxis post-stabilization, and that would be in cases where perhaps you have a child who's had a recent exacerbation of their asthma, and there's a feeling that that might have contributed to a severe allergic reaction to perhaps a known allergen. So we should be giving those via the oral route, and oral prednisolone would be useful at the same doses that we would use for asthma management. So moving on to BeatAnaphylaxis, I'll give you a bit of a background about me. So I was a trainee in Region throughout my registrar years, and during that time I worked in lots of different settings throughout the region, different types of paediatric care. And during that time I came across anaphylaxis multiple times, either acutely or post-acutely. And one of the things that really struck me was the variability of the care that these children and young people were receiving. It got me to thinking, well, I know there's guidance, but we're not doing the same thing. I started to want to understand really clearly why that was. So I engaged in some clinical governance activities, some single centre multi-year audits, and then some multi-centre audits. And throughout all of those exercises, I started to understand key themes in these audits in different places. And I started to understand that perhaps through discussion with colleagues, there might be a better way for us to be able to be equipped to manage these cases. And we started thinking about a toolkit that we could use of information, of documents, of management algorithms that might help us have a more consistent approach. During that time, I witnessed the really impressive rise and use of online information platforms for healthcare professionals, teachers and patients in the Beat Asthma project that Dr. Jen Townsend had started up. We kind of retasked the similar principles, and with her blessing, we went on to outline a Beat Anaphylaxis quality improvement project. So what was that project? Well, very briefly, it involved 5 phases: baseline data gathering, looking at a regional audit, which had never been done before for cases of paediatric anaphylaxis, and a health professionals knowledge survey. And then a development phase where we would co-design resources and a website platform, BeatAnaphylaxis.co.uk, to support mainly healthcare professionals, but also educators, and in particular patients and their families, better manage their condition, their risks for anaphylaxis, and indeed those acute episodes. We then had a 12-month implementation period where we launched the website, and then, much like today, promoted its use amongst relevant stakeholders. Finally, there's a evaluating impact phase where we would perform the re-audit of clinical care 2 years later and repeat the knowledge survey across healthcare professionals. There's also some analysis of web user analytics, frequency of downloads of particular resources, and then some focus group work to see how the application of the resources was going and consider improvements and refinements. So we've completed phase 1, phase 2, phase 3, phase 4, and we're partway through phase 5. And I'll talk to you a little bit about some of those post-intervention data sets that we've got. So first of all, the initial audit, what did we find was the existing practice? We did a whole year inclusive retrospective case notes audit of all cases coded for paediatric anaphylaxis. We compared the care delivered against the NICE guidance, clinical guidance 134. And we looked at cases across those 7 trusts. And as I said before, 75 cases, a really nice distribution proportional to the paediatric populations that each of those organisations serve. So what were the findings? Well, largely, I'm going to summarise them because there were loads of findings, but key areas with discharge information. And we found that about 2/3 were not given, 2/3 of cases, there was no documented evidence of any discharge information given to patients, which was absolutely criminal. Drilling down into those that were given discharge information, we found that really key mainstays of prevention and managing anaphylaxis well in the community, such as allergen avoidance and allergy action plan provision, were only done in kind of around half of cases. Things like support groups, things that can greatly empower families and young people and children to manage anaphylaxis and reduce the risk of it, were done in a very, very small percentage, just 11 out of 75. Information about biphasic reactions, things that can happen post-discharge, rarely were also not really covered. I'm going to skip over mast cell tryptase, mainly because it's a diagnostic which can be used and there's a criteria, but it was poorly used by healthcare professionals in secondary care mainly. And I guess the biggest finding, the thing that made me most worried, was that 1/5 of cases of anaphylaxis where provision of adrenaline auto-injector was indicated when looking back at those cases didn't receive any of this potentially life-saving medication. So back to the project outline. And I'll talk about the health professionals knowledge survey very quickly. So we looked, we had a really good response from about 300 professionals, a range of roles, experience, seniority across primary and secondary care. And not surprising, confidence scores for managing anaphylaxis or recognise it increased with the experience of the respondent. But actually there was evidence that there was a very poor understanding of anaphylaxis recognition, which kind of complemented the findings that we had from the audit. So just 10% of people recognised that persistent coughing could be a cardinal feature of anaphylaxis, and less than a third of people recognised that hoarse voice was a sign potentially of airway compromise in anaphylaxis. There's confusion about mast cell tryptase, which again fits with our audit data. And there was uncertainty about what I mentioned before, this idiopathic anaphylaxis, triggers identified, and indeed who should receive adrenaline auto-injector upon discharge after an acute anaphylaxis. So website, what did we do? What was the intervention? Well, we looked at all of the stakeholder groups, but we held the key element was holding face-to-face and virtual focus groups with primary care and secondary care, so these healthcare professionals. And we used the themes that we got from the audit and the knowledge survey to infer how we design those resources with those stakeholders, rather than having resources designed by, you know, tertiary allergists or people who were operationally planning care. We also looked at education, and we engaged early years primary school and secondary schools to also co-design their specific resources. And finally, we had some patient-facing interaction with the Young Persons Advisory Group Northeast, which was really eye-opening and incredibly rewarding. I was really proud. We had a lot of people give up their precious time to develop 25 bespoke multimedia resources across those stakeholder groups for the website. So if you haven't already, I think the QR code's been hovering above my shoulder. But if you haven't already, please scan the QR code and have a look at the website. And you could also get to it via the URL at the bottom of the screen. So this is the home page, and what really does it feature? Design was that it would be a jump-off resource website, so it doesn't have everything you need to know about anaphylaxis in it. We haven't designed and redesigned resources that were already high quality and out there in the public domain, but we have allowed it to be a single point of access to access the information you need. So we do have some bespoke healthcare professional resources. We've also got links to the current guidance from the Resus Council, which we've talked about, and NICE. We've got links to the British Society of Allergy and Clinical Immunology Personalised Allergy Action Plans. We got links specifically to the wonderful manufacturer of these adrenaline auto-injectors websites and apps, and all of the great video resources that didn't need to be reinvented can all be accessed via this portal. So you don't need to remember multiple resources, you just need to signpost patients and families to this, and indeed look at the resources yourselves, because there's some healthcare specific ones. There's support information and links for patients and families that we've designed based on that co-design process and the needs of the users. That's one of the major strengths of this, is that when you discharge your patient, you can really give them something to look at home and explore and consolidate some of the teaching and training you've given them. We've also got some education packages for healthcare professionals and links to further training, more formal training with university courses, e-modules for healthcare professionals, and the Royal College of Paediatrics and Child Health paediatric allergy training courses. Finally, as a latest research hub, just to kind of stimulate those who want to take their knowledge a bit further. So I was really proud. We had a wonderful launch event, webinar like this, online in January 2021. About 80 people from across healthcare, education, and some patients and their families attended. So adrenaline auto-injectors, risk assessment, very common question I get asked: who needs to have pens? And I often go through exactly the criteria and tell people. And I realized that we put so much work into the website, and there's a really wonderful resource and document for all practitioners in hospital, but also in primary care, to look at. So again, I direct you for that question about who gets these pens. Of course, if you've had anaphylaxis, you're going to get a pen, unless it's something that you can easily avoid, like for instance, an immunization or an IV drug or something like that. But other things that you potentially can't avoid and you may come across, we're going to give a pen for. But there's some other groups which are at risk, those with, for instance, moderate to severe or unstable asthma. Those which live very rurally might be a partial indication for anaphylaxis. So this guidance is very useful, and I recommend that you scan the QR code and look at the healthcare professionals section to see that PDF. Finally, the website also has these links to the allergy action plans, which are essential if you come across anyone with anaphylaxis or you think they're at risk and you're going to prescribe some medication. So you can get to those through this. You don't need to Google anything. You don't need to remember anything. BeatAnaphylaxis, and Sister Langley is going to talk to you about that now. So finally, evaluating impact. So I'll talk to you very briefly about the REAUDIT and the highlights and what we've gotten to after over a year of really hard work promoting the resource. So the provision of discharge education and anaphylaxis, you remember before that we were kind of under or just over 2/3 of people that were getting any documented discharge education. We're now up to 85% when we re-audited. We've also got improved blood pressure documentation, something that surprisingly was missed in 15% of the original cohorts of patients. We've got a reduction in adrenaline indicated but not prescribed rates. So it was around 1/5, it's now down to 13%. And we've got increased signposting to organisations. You remember those very small number, 11 out of 75 on the initial audit. We're now signposting to certain organisations or something in 45%, and 30% of those who had anaphylaxis were signposted to BeatAnaphylaxis. So quite a long way to go, but actually a resource that didn't exist then is now being used and hopefully helping practitioners, patients and their families. And there was also improved rates of time of onset documentation and allergy specific information that's really key to help diagnose anaphylaxis. So yeah, we're a slight improvement there. So things that weren't so good, we're still doing in less than half of these patients. We're not giving them allergy action plans, and you'll see that's a theme throughout this talk that we will emphasise. These need to be used. They're nationally agreed plans. They've got RCPCH endorsement, also those really important charitable organisations there as well. 30% of those prescribed adrenaline were only given one adrenaline auto-injector, and we know that each patient has to have sets of two and access to two pens at all times. 21% of those prescribed adrenaline did not receive any training in its use. So surprise, surprise, if you are given something and you don't know how to use it, you don't use it. And although there is information on the allergy action plans, which only half of people are being given, and these little diagrams on the pens themselves, it's not enough. And we typically see even well-trained people don't always use their pens. So we're increasing the chance of them not using this life-saving medication. So finally, we repeated this healthcare professional survey, and we haven't fully analysed the results, but we had a similar amount of respondents across primary and secondary care, range of different types of experience, roles and seniority. 50% of those who replied, who responded, were now aware of BeatAnaphylaxis resources, which is I'm quite happy with, but I realise that we've got a ways to go. And of the 36% of those who were aware, 36% had used the website in clinical practice to aid their management, which I was quite pleased about. But again, lots more to be done. So I've rambled on quite enough. You'll need a break from my droney voice. So I'm going to hand you over to Sister Lisa Langley, who's going to talk to you about some devices.
Thank you, Andrew. So I thought I would just start by saying a little bit about who I am and where I work and what predominantly my role is. So I've worked in the Queen Elizabeth for 24 years, and for half of that time I've also been part of the Allergy team and worked in the children's outpatient department, supporting the children and families. And my main role within that is, as well as performing the skin prick tests, I also do a lot of the education, training the children and families with how to use the adrenaline auto-injectors, but also giving practical advice and tips to them with how to help them to manage things on a very, very practical level. And that includes using the allergy plans with them, which is a negotiation with the family as well, picking out things that their concerns are and how I can help with that, and just explaining how life can be, that they worry a lot about the impact on their life and their child's life. So hopefully I can make that a little bit better. Predominantly I work within the emergency care setting, so I feel that's really useful. So not only do I see the children when they come in as a first point of entry, children that already present that have an allergy and they come where they've accidentally been exposed to an allergen, but also those children, the babies that Andrew's already discussed, that are trying foods for the first time and they present with allergic reactions or anaphylaxis. And I see my role a little bit, as well as educating all the nursing staff, so it doesn't just depend on if I'm on duty or not, is to try and educate the staff with how to bridge the gap between being seen in the emergency department and then being seen in the children's outpatient clinic, because for the families it's quite a stressful situation, and they're coming, they're really anxious about what this means for the child and how they can manage it. So I like to try and, if I can, just alleviate a lot of their anxieties, answer their questions, and I also do a lot of training with the staff around that to try and enable them to be able to do the same if I don't happen to be there. And this includes training the nurses on how to administer the adrenaline auto-injectors, because we expect the families to do this, but also a lot of trained staff can really worry about also administering this treatment. I also can advise with regards to putting investigations in place in the first instance in the emergency department with regards to blood tests, which creates just a more seamless pathway for the children when they do then come to clinic. Also, that is a great time if you don't know what to say or you're worried you're going to give the wrong advice. We do have the QR codes in A&E, and we do the families love that and they use that. So if you're unsure if you're going to give the wrong advice, they can scan the QR code. And I've even used this if a child's presented but the parent has an allergy, and through conversation they've been anxious about their allergy. It just gives them some information, helps to empower them, because ultimately it's the families that are at home looking after their child. So I see that as really helpful to work over the two areas. When we're talking about professionals, we've identified, to echo what Andrew was saying, that a lot of professionals either don't recognise or worry about, how to manage anaphylaxis. And I'm in the process of developing 2 anaphylaxis grab boxes to be kept on our resus trolley just for paediatrics, on our day unit, which covers outpatients as well, and in the emergency department. So all of the equipment and the drugs and the guidelines are all kept together. So we tell the families at home, if they need to administer it, to try, to have everything together. But then as professionals, sometimes we can be guilty of, where's the adrenaline? Have we got this? Have we got that? So to try and make that, so the intervention is very quick and very smooth if the children need it. I'm in the process of creating that too, just to enable everybody to be at the same level. So I'm going to talk a little bit about the adrenaline auto-injectors, and there's two main ones that we use. The first ones are the EpiPens, so I'm going to discuss both of them. We have EpiPens and Jext. I'll talk about EpiPens first, and then there are subtle differences between them. So the EpiPens, if a child's above 25 kilos, they get the larger dose of the 300 micrograms. And if the child is between 7.5 and 25 kilos, then they have the lower amount of the 150 micrograms. Not for home, but in the hospital as well, we also do have for the babies, if they need them, we do have the made syringes with the smaller doses in if we do have a very small baby that does have anaphylaxis as well. So the plan that the child goes home with should accurately reflect as well which pen they are being given. So if they're having an EpiPen, their allergy plan should state that, because they have got ones for Jext too, and for if the child doesn't need an adrenaline auto-injector. So really important as professionals that we ensure that we are giving the correct plan to the children and the families. And then that is the Jext pens on the right hand side. If the child's above 30 kilos, they get the 300 microgram device, and between 15 and 30 kilos, then they get the 150 microgram device. So with regards to administering the EpiPen, As Andrew was saying before, the patient should be lying down with their legs slightly elevated, definitely not standing up, because obviously with anaphylaxis, they can have a drop in blood pressure. And this is something that I do try to hammer home with the nurse that's triaging the children, that it's the subtle things that the families are saying to us that we really need to listen to. We all can kind of look at a child that's got a florid rash with urticaria, really swollen eyes, and be concerned about that. But sometimes it's the child that has less of a rash, but they've got an altered voice, or the parents say their cry just sounds a little bit different. Obviously, if there's any drooling, that's more visible. But to ensure that a blood pressure is done at the point of triage as well, and that can sometimes be missed. And it's really, really important. So the child should be lying down with the legs slightly elevated. I quite like to explain to the children and families, orange to the thigh, blue to the sky. So it just enables them. It's very stressful for the parent to have to give their child this medication. So we try and kind of think of things to make it a little bit easier for them. And the devices are now also needle safe, and that's helped greatly reduce the instance of parents receiving or carers receiving needle stick injuries. So it should be held in your dominant hand with the blue safety cap closest to your thumb. Once the cap's removed, then it's ready to go. So it should be pressed at a 90-degree angle. It's more of a swing with the EpiPen to the outer thigh. And I say to the teenagers and even to any child, it can be given through clothes, because especially the teenagers, they would worry if they're out and about with their friends. Do they need to be kind of pulling their trousers up, or, they worry about things like that. So it can be given through clothes, but just not the seam of a jean, because that's too thick and could affect the administration of the adrenaline. So it should be a 90-degree angle. And you swing and you hear a click, and that means that the adrenaline's being administered. For the EpiPen, it's advised to hold in place for 3 seconds and then remove it. And that also, and again, this is very important when going through the allergy plans, that it's not just about treating the condition, it's about following that up and then getting help, because a lot of the reactions are in the community and they need somebody to then come and help them with that. So it's always about following that up with a 999 call and asking for an ambulance. It says to state anaphylaxis, which for a lot of our families, that's quite a difficult word and they can find that hard to remember. But what I like about that is that it's broken down on the allergy plan phonetically to help the children, the older children, if it's them, or the families or carers, to be able to state anaphylaxis, which really helps the crew that are responding to that incident. And the patient should be kept lying down for the reasons we've discussed earlier until the crew arrive. If there's no improvement after 5 minutes, it's advised to give the second EpiPen, and this is why it's crucial to always ensure that the family have 2 devices. Alternatively, the Jext pen. On a personal note, a lot of the children say that they prefer this because they're rounder, they're a little bit easier for the child to hold, whereas the EpiPens are larger and flatter. So that's just a personal thing that children have said. They should again be lying down with their legs elevated. It should be held in the dominant hand. And for this one, we can also say black to the thigh, yellow to the sky. Where the sunshine is, I usually tell them, so it helps them to remember which way around it goes. Once the safety cap is removed, then again, that is ready to be administered. So it's more of a push for the Jext pen, so just a push to the outer thigh, and then again, you can hear that is being administered. It clicks. And then for the Jext, it's advised to hold in place for 10 seconds before you remove it. And the difference here is that the site, it advises that it's massaged for 10 seconds to get the adrenaline all around the body. But what I do say to families is, because they can be concerned about what if they give it the wrong way, or what if they've gone home with a Jext pen and then the GP prescribes an EpiPen, I try to just reduce that anxiety by saying that if they were to massage after the EpiPen, it's not going to do the child any harm. If they were to hold it in place for 10 seconds instead of 3, again, it's not going to do the child any harm. We don't want to concern them. We just want to enable them to be able to administer the medication that the child needs. And again, really important to then dial 999, state an anaphylaxis, and getting extra help from that. So the allergy management plans, this is something I'm involved with quite a lot in clinic, but also in the emergency care setting. I do ensure that the children go home with these and advise, when I'm not around, to inform the other nurses that they should be prompting, medical staff if they're not aware of it, because they change a lot of the time and we are a constant there to ensure that the children go home with this. And really important, although it seems a small detail, they should be in colour, which can sometimes, be a bit of a problem with equipment, but they should be in colour just to emphasise the things that are important. They are individualised for the child and family, but they can be updated on a regular basis if things change or new things need to be added. From clinic, we usually give the families 3 copies. We print 3 off. 1 stays with the notes, 1 should go with the parents, and 1 goes to the school. And if the family have a grandparent or a relative that cares for the child on a regular basis, they can then decide if another family member requires that. It's split on the right-hand side. It has the ABC approach for recognising the signs of anaphylaxis and also shows the position if you need to administer the adrenaline auto-injector. And on the left-hand side is a blue box, which just it's helpful information. If the child vomits as part of their reaction, which we often see, then the antihistamine can be repeated. And it also has a parental consent box that for when the child goes to school, that the parents can sign, that the teachers can administer, which does help from an educational point of view because they do need consent for the medication. Excuse me. So we've talked about the fact that a lot of the instances happen at home or in the community, and they're not in the hospital setting. I've had a lot of chats with parents that say they've driven to the hospital and they've parked in the car park because they've been anxious about giving the adrenaline, and what does that mean, and what if they give the adrenaline and the child didn't need it. So I always try and reassure them that any healthcare professional should never ever kind of say, oh, I wouldn't have given that, or maybe they didn't need it, because if the child's in front of them and they perceive they are assessing the child, they are looking at the child. And if they think that the child needs adrenaline, then that's something that they should do. And they should never be made to feel, guilty for that. And I'll say to them, if you give it and they didn't need it, the worst that'll happen is they might be flushed. Their heart might beat a little bit fast. They might be a bit clammy, but that will all settle within an hour or 2. What we don't want is the families to worry about giving it and not give it when they should be having it. So it's all about empowering the children, the families and the carers. We talk a lot about the 4 A's. So awareness of the allergen, avoidance of the allergen, and antihistamine if it's required. And hopefully if the first 3 are well managed, they shouldn't get to the 4th A, which is adrenaline. But if they need it, then it's there and they shouldn't be worried about giving it. And we need to make sure the education's really robust so they feel empowered to do that and supported with that by the healthcare professionals. And again, it's about sharing the information with the people that need to know. So I've trained a lot of families in with older teenagers. I'll often say, have you got, a friend? Because they're often not with their parents. So a good friend that, needs to be trained in that as well, in case they were too unwell to administer the pen themselves. Excuse me. A lot of kind of the practical problems we do discuss with around this as well. So we discuss kissing contact is a huge thing that we talk to the families about. In younger children, it can be grandparents, aunties, uncles that can eat an allergen and then unknowingly just kind of kiss the child or touch the child, and the child can have a reaction to that, which can be anaphylaxis. And in the teenagers, really, really important because they are quite at risk because they're not with their parents a lot of the time. So we talk about girlfriends, boyfriends, kissing contacts, sharing drinks, and things like that, practical tips that are really important for the children and families. We also really recommend that they have a kit with everything together. So in this emergency kit should be 2 pens of whatever type that they are. Their allergy management plan should be in there. If they're asthmatic, their inhaler should be in there too with their spacer. But the only thing that they should not store in there is the trainer pen, because the parents in a stressful situation may pick up that trainer pen and think they've given adrenaline when actually they haven't. We also really sort of hit home with the allergy plans that if the child is asthmatic, they must give the adrenaline first. And that's really, really important, because they might be wheezy, they might have a B problem, and they might be wheezy. But if they give the inhaler first, that wheeze is just going to come back because they haven't given the life-saving treatment, which is the adrenaline. And also within that, it's really important in the emergency care setting and in the outpatient setting to just signpost, because it might be that only one parent can come or grandparents need to know. But if we signpost through the BeatAnaphylaxis QR code, then there's a lot of training videos there that the families can access, and that's a really useful resource. These emergency kits should also be at school with all of those things in, so one at home and one at school. So if the child needs it, everything's together and it's labelled, and that also can help reduce anxiety within the school setting for the teachers. The thing, and I really like this because it's easy to remember, the kit should be to hand, it should be in date, and it should be ready for use, and the family should be able and trained to use that. And that is definitely, as professionals, that is our job to enable them to do that. I also tell them about the dates of the pens, because there can be a difference. If they've got 2 pens, those pens can have different dates, and you can set up reminders, be that a text reminder or an email reminder. They can receive that to their phone, because lives are busy and it's not something that you're going to give all the time. But if you need it, you want that drug to be in date. And if we were giving any other medication for home, we wouldn't be sending families home without any training on how to administer, tablets or anything. So we shouldn't be sending them home with adrenaline without the correct training. So the things that really I wanted to kind of hammer home was the 4 A's, and just good education and explanation. That is, as nurses, and I'm obviously talking from a nursing perspective, that is really our role. And there's nothing more satisfying, and we've had really good feedback from the families when they've had good education. And they've had that time spent with them in the A&E department, and that good advice. It has made a big difference in the management, that confidence with dealing with their child and managing their condition, because it is very, very stressful. And we can help with all that when they come to clinic. We can have a different approach and have more time with them. But that's crucial if they're presenting for the first time in A&E with anaphylaxis. That family are very, very stressed and anxious, and they do need a lot of support, and they do need education, and that should be regardless, anybody who's on duty. So I'm really passionate about the nursing staff being up to speed with how to give this to, and use of the QR codes from the BeatAnaphylaxis website is just so useful, and we have them to hand in every department and we use them regularly. So I'll just hand back over to Andrew now, who's just going to summarise what we've talked about.
Well, thanks very much, Lisa, for that fabulous tour around adrenaline auto-injectors and talking about some really important, useful, practical tips about how to deal with families and educate them better. So, summarising just briefly, I want you to remember that anaphylaxis is a low frequency event, thank God, but it can kill, and it can certainly make children really sick. So it's really important. Anaphylaxis features, they can be subtle, as we've kind of alluded to throughout, and that part of the allergy action plan, those subtle features, that persistent cough, recurrent cough, the change in the quality of your voice, those type of things are often the things that fox us. The absence of those mucosal changes, that urticaria hives or angioedema or swelling, those are the things that really misdirect us when we're thinking about anaphylaxis. I want you to remember that sudden changes in posture are not good, and we should try and avoid them, and we should try and keep a child or young person having anaphylaxis in the supine semi-recumbent position, sitting or lying down, legs elevated if you can, especially during treatment. Early recognition is really the key, and if you forget nothing else, IM adrenaline is the only thing really to remember. You want to give that promptly. You also want to repeat that dose in the contralateral thigh on the other side after 5 minutes if there's no improvement in the symptoms of anaphylaxis. Finally, don't worry so much about antihistamines. They are useful after you've stabilized a patient, but you don't really want to be messing around with them when you think it's anaphylaxis. It's about adrenaline. If you're going to use the antihistamines, let's use the non-sedative type, so cetirizine in place of Piriton. And we don't want to jab people with injections of antihistamines or corticosteroids in the emergency management of anaphylaxis. Finally, patients, their families, they really need adrenaline auto-injector training, especially when these are prescribed. If you're not sure how to prescribe them, have a look whether this patient needs it, and you can see all of those things on BeatAnaphylaxis. So I think you're all discovering a theme for this webinar, which is to use the QR codes or just type in the URL into Google if you can't remember the whole thing, and you will find the site. Please remember, if you're managing pediatric anaphylaxis, think BeatAnaphylaxis. And, you know, we've created this website for everybody in healthcare, primary, secondary care, it doesn't matter. Teachers, educators, they have their own section, patients and their families, their own section. So I'm hoping it's a really versatile, useful resource. It's the QR code there. We can send that round on the mailing list for people to save. I like to have it on my phone, but then I'm a BeatAnaphylaxis geek, so I don't expect you to all have it on your phones, but your department should probably have a laminated copy on the wall, maybe in Resus, maybe on your day unit that's doing allergy challenges, maybe in other areas. I'd really love for you, if you're ancient and elderly like me and on Twitter, to follow BeatAnaphylaxis on Twitter, and you can see some really exciting things that are happening later on this month. A launch of a family story about Ellen Raffel, which is really emotional, and I think will be really useful in raising awareness. Now's the time. I think we've got about 7 minutes. If there are any questions, I've had a little look at the chat, but there might have been some things crept in while I've been summarising. But I'm happy, and I think Lisa's happy to take any questions now if you have any. Those are the references for the talk.
Thanks, Andrew. And Lisa. That was excellent. That was really useful. I think, having used BeatAnaphylaxis myself clinically and since being in this role, it's a wealth of resources that are not only really well built, but really practical as well in terms of the ability to access them. So I would encourage everybody to use the QR codes. I did have a couple of questions, actually. One was about the grab boxes that Lisa was talking about, which sound like a really excellent idea. And I wonder if we could share a sort of pro forma for what should go into those so that we could use them more regionally and sort of get a standard set for what should be going in them, and so that other units can mirror them, because they sound like an excellent idea. And then the second thing I wanted to ask was, we've had some requests through the ODN about training for community staff regarding adrenaline pens, and community staff are seeming to be going out in September, particularly at the start of the new year, to do a whole raft of adrenaline training, and whether we could look to put some video resources together for that, or if they're already available on the BeatAnaphylaxis site.
Yeah, so I think with regards to the grab boxes, I don't know if you want to say anything, Lisa, about those. We're quite early on in that process, but we'd be interested to share good practice.
Yes, I would be happy to do that. Literally, we've got everything set to go. We're just waiting for the boxes to actually put them together, which should be arriving in the next week or so. But yes, I'm happy to do that.
Great, thanks.
And the question about certainly community nursing, and I think yet another task that they're being asked to do is train all of the teachers in the Northeast. Does anyone have an idea how many schools, just schools, not early years or nurseries, how many schools there are in the Northeast? It's kind of a rhetorical question. I am a geek and I've been doing lots of work with schools, and there are over 1,400 schools in the Northeast, so maybe that's a tip of an iceberg. There's no way that any of us healthcare professionals can provide what those schools are really wanting, which is face-to-face training on how to administer adrenaline. I looked at it and it's just undeliverable. But one of the things that we are working towards in BeatAnaphylaxis, and indeed the next stage of project, which I've almost got fully funded, is to look at how we can better empower schools, not only to know how to give adrenaline, but actually to have a framework for providing the appropriate care for children at risk of anaphylaxis and allergies in their settings, and to allow them to accredit themselves once they've reached a benchmark, a standard across all staff, and how actually we can perhaps use things like peer review, local educator champions who are expert in administration. We may be able to update one person per school potentially across a wider network, and then have online resources, video content and things, as well as a training package for every member of staff that we can deliver it. So it's in the pipeline right at the moment. The best thing that we have, if you are going to deliver that training, is I'd recommend going to BeatAnaphylaxis and looking at the adrenaline auto-injector websites, where all the links are under the resources for healthcare professionals, but also for patients and families. The videos are really useful, not only to refresh your knowledge, a bit like the session that Sister Langley's done today, but also to think about then saying, right, we're going to do this. I've watched the video. I remember how to do it. I've refreshed. This is how you do it. Now I want you to go and talk your family through how to do it with using this video resource. And guess what? Here's the QR code for BeatAnaphylaxis. This is the website. This is how you're going to look at it. So that's probably, I think, the best thing we can do at present. But there are wheels in motion and a broader project to try and empower schools to be able to deliver the appropriate care to all their students at risk. Sorry, bit of a long-winded answer.
No, well, I think it's really good to see that work in progress, isn't it? And as always, there's always more work to do, isn't it? So if we can champion this platform, which is a really, really useful resource to everybody within healthcare and education, then I think that's it maintains that standard, doesn't it? There are a couple of questions in the chat box. I don't know if you can see those, Andrew. The one is from Amanda, who says, how long should a child be observed in hospital after a child is systemically well after administration of adrenaline?
Really good question. I think there are two answers. One is the new guidance, which I started to talk to you about, the RC UK guidance in 2021. They suggested something new and controversial about you risk assessing what type of severity of anaphylaxis, so either I think it's something like mild, moderate or severe, and based on that there is a subgroup that you could discharge after 3 hours. Okay, I'm on a national steering committee for anaphylaxis. I do a lot of work. I speak to a lot of people about it, a lot of allergists and just kind of general paediatricians like myself. I think the overall feeling, unlike the steroid question, which I think there'll be some movement in how we're practicing, even though it's a big change, is that 3 hours is too soon. I don't think people are ready to be able to confidently risk assess those children and send them after 3 hours. So I would say minimum 6 hours, but depending on the level of compromise, the amount of adrenaline used, the type of compromise, so like, you know, an airway compromise is probably more worrying. Laryngeal edema is probably more worrying than wheeze, which settles with one dose of adrenaline. You may find that I think up to 24 hours would be reasonable. So 6 to 24 hours is what I would say is the practical answer. But technically, if you start looking at that guidance, you'll say, oh, Dr. Bright, you're wrong. It's 3 hours in some cases. I'm happy for people to take that responsibility on themselves and discharge people after 3 hours, but I wouldn't be doing it personally. And I think there's a lot of other people that are going to stick with the 6 hour mark. Our audit standard was the 6 hour mark, and that's still the NICE standards, which may change. But yeah, 6 hours is the minimum. Mute.
Great,
Sorry.
thank you.
Sorry, I was just going to say, from a practical point of view, if it depends on the
Andrew, you might need to mute, sorry, while Lisa's speaking, because we're getting a bit of feedback.
I was just going to say, from a practical point of view, to me, I always bear in mind what time the child came in. So if they came in later on in the day and they could go home at say 11 o'clock at night, if the parent's going to go to bed and sleep all night, if there was going to be some kind of rebound reaction, we often tend to keep them till the morning and send them home in the morning, because if it's through the day and the child's going home at lunchtime, they're around the parents, and if there was any problems, there would be more responsive to that because of the time of day it is. So I'm always really cautious if the child could go home very late in the evening, that actually it might be safer for that child to stay overnight and go home as an early morning routine.
Great, thank you.
Yeah, that's a really good point.
Any more questions from the group? If not, we'll make a close out of the webinar. Thank you, Andrew and Lisa, so much. I think that's been really informative. As with all of our ODN webinars, we will put this onto our ODN website, and I'm sure Andrew will be sharing it on the BeatAnaphylaxis website as well, and through the NECTAR website, as we're working all in collaboration with each other to promote these resources as much as possible. Going forward, we will be sending out evaluation forms to everybody who's attended today's session. Please do fill them out. We do find them really useful in order to sort of formulate the training and things that we deliver through the ODN going forward. And obviously, Andrew is very keen to get to feedback on the session today regarding his talk. Once you do send the evaluation back to myself, then I'll be able to send you out a certificate of attendance for today's session. But please do share with all of your teams that once the sessions are available on the website as well, they can still get certification for watching them. They just need to send me an email for an evaluation form. So all of the details for those will come out with the evaluation forms once I've got the attendance list from our administrator and today as to who's been on. I think there was one other person that was watching with somebody on a dual computer. If they could just drop me an email with the address. Is it Gemma Sutton? If you could just drop me an email with your address, or Tracy, who you're watching with, and that helps me just formulate the emails who I need to send out to. But with that, I'd just like to thank Andrew and Lisa again for that excellent talk, and we'll close off today's webinar. Thank you.
Thanks. Cheers.